She shouldn't be alive today. Yes, Lynn shouldn't be alive today. When I first arrived at the church, basically was clinically or medically dead. No pulse, no breathing, fixed dilated pupils, and the length of time that she'd been unconscious was quite considerable. So at that stage, you know, I could have said, sorry, she's gone, and you know. We'd arrived at church probably a bit later than we would have been ordinarily, and there was a young fellow standing outside the front of the church, and he was directing folk around down the side and into the hall at the back, and he said, look, somebody had collapsed in the church, and would we mind going through to the back? And I remember I had a sort of a bag with me, and I gave that to me, and I said, well, I better go in and have a look. And I thought, oh, you know, maybe some old ladies had a faint or something like that, you know, they get all dressed up, it's hot, and over they go, because that's often what happens in a church setting, and yeah, that wasn't the story at all. I remember walking into the foyer, all the family obviously was standing outside looking very tearful and stressed, and then in the church at the back, pretty much in the middle, Lynn was obviously lying down, head towards the door, and there was two ambulance crew, and one other lady, who was a nurse that was in the congregation, were there. The paramedics had connected her up to a monitor, and were busy putting a drip in her right arm, and the nurse was sort of maintaining the airway. And I think I'd arrived at a break in the CPR process, so they were just having a reassessment of what was happening to her rhythm. Was there a pulse? She had a very poor rhythm on the ECG, just a few sort of beats coming through every now and then. It wasn't what we call a shockable rhythm, so we couldn't use a defibrillator on her to get the heart started up, and that's not a good sign. If you've got a rhythm that's what we call shockable, you've got a much better chance of getting the heart started up. My understanding was that she'd had what we call a downtime of about 20 minutes, maybe more by then, which is also not very good. She had a fixed dilated pupil, I think, on the right-hand side. The other pupil wasn't responding either, and really it had no useful output in terms of her own circulation since she'd collapsed. So while the paramedics were finishing up with the drip, I started the cardiac compressions again. Once they got the drip and they were able to give us some more advanced life support stuff, some intravenous drugs, they gave us some adrenaline to see if that would get things going. During the sort of the cycles of the CPR, she had a few more doses of medication, and we just got to the point where I was thinking about we're probably going to have to intubate her. And then at the time there was supposed to be a divert of all urgent cases through to Burnie. My feeling at that time was that she wouldn't have survived a trip to Burnie, so I sort of told the ambulance crew, look, don't take her to Burnie, she won't make it, take her to the Mersey. Now they were quite relieved that I'd said that, because I think they were wanting to do that, but were worried about breaching protocols. If someone else on the scene says don't, you know, who can sort of supersede you in a superiority point of view, which I was able to do, being the doctor in the scene, that gave them an out, as it were, so that, you know, and so that they took her through there. I mean, I'm quite sure she wouldn't have survived if she'd gone to Burnie. I know she had a cardiac arrest again on the way to the Mersey, and then when she got to the hospital they needed to defibrillate her and start her up all over again. So basically by the time she'd got to the Mersey she'd had at least 2 cardiac arrests, and then she had another one in the emergency department, so that's 3. Okay, so not many people survive 3 cardiac arrests. I was sure that the diagnosis was a pulmonary embolus because she'd had the cast on her leg, and she had quite distended neck veins, and those are typical things that you get a sudden collapse. And she was a young and obviously fit and healthy person, so they're not the sort of people that tend to have heart attacks or strokes or anything like that. So she needed urgent treatment, and the treatment that she really needed, apart from the sort of advanced life support and the oxygen and all that sort of stuff, was what we call thrombolysis, which is medication to break down the clot in her lungs, so that you can actually get blood into the lungs and then through the lungs to pick up the oxygen to deliver to the rest of the body. So she would have had that shortly after arriving at the hospital. So that would have helped to break down the clot, or to stop more clots from forming, so that she could get good oxygen into her system. But then one of the side effects of that medication is that you can have bleeding, which she subsequently went on to have, and she had a bleed into her brain and then had the stroke. So she survived the pulmonary embolus, 3 cardiac arrests, and then had a big stroke, which probably should have killed Okay.
That's right.
Yeah. And I think at that stage she'd been through so much and survived against all the odds that people probably could have sort of given up at that stage. But I think the feeling was that because she was fit and healthy, it was worth trying further things, and hence the referral down to the team at the Royal Hobart. And then the neurosurgical team would have to take over there and decide what to do with her. So she had a very tough time down there. From what I recall, she did have something called a DIC, which is a disseminated intravascular coagulopathy, where all the clotting factors are consumed and you start bleeding again, and so that makes it difficult. So she had surgery, and she had a procedure to reduce the pressure on the brain, and she probably shouldn't have survived that either. But at that stage, you know, if nothing was done, the outcome would have been death. There's no doubt about that. Or if she had survived it, she would have been severely disabled. So it was now a case of seeing what they could do to preserve her brain function. And it worked, really. You know, along the way there would have been plenty of opportunities to sort of stop and say, look, we've given her a good go, let's try it. When I arrived at the church, she'd been, you know, she'd had a downtime of 20 minutes or more. It was probably longer than that, to be honest. If I'd said to the ambulance crew at that stage, look, I think we can stop now, guys, you've given her a good time. She'd been at downtime 20 minutes, no pulse, no respiration, you know, dilated pupils, one's blowing the other side, we could stop now. There probably would have been, it would, you know, would have been medically probably quite acceptable to do so. Wouldn't have had many people argue against that. And similarly, once she got to A&E, but the fact that she sort of stopped and started, I think was just an indication that this is a fit, strong person. You know, with some extra support, you might well get a good result. You know, if she'd been 20 years older, it would have been very much a different outcome. I remember speaking to you on the phone when you phoned from Hobart once, and there was some questions about what to do. You know, should she have this operation? Should she not? And, you know, she might end up, you know, in a permanent vegetative state or permanently badly disabled, and then what? You haven't done her any favours. But you know, doing nothing would have been death. Doing something might have been anything from, you know, comatose to maybe a full recovery. And except for a hand that doesn't work well now, she's recovered everything. You know, so I'm quite certain I'll never see another person that has a cardiac or respiratory arrest out in the community and then has all those complications and ends up as well as Lynn has. You know, so from my point of view, it's, you know, I think it's miraculous that she actually has recovered as well as she has. I think you'd go a long way to find another doctor in Tasmania or who can recall in a career of 20 odd years having a patient in the same situation who had all those complications that ended up as good as she has. And so I'm quite sure I'll never see another patient that does as well as that. And so from my point of view, as I said the other night, you know, that sort of 15 or 20 minutes that I was working on them with the paramedics was probably the most rewarding 15 or 20 minutes of my medical career. You know, it's just one of those things, you just never know how well people are going to go. And so I think, you know, someone in that sort of situation, just throw everything you can at them and just see what you get. You know, if you get a good result, you'll be very happy. If you didn't get a good result, well, you know, at least you tried. It's better than not knowing, I think. So yeah, I think it's pretty much a miracle that she's done as well as she has.